Okay, guys, so I'm here. Let's start. Let's not wait much. So, I welcome you, everyone, to this free webinar and demo class on the ECG, echo, and angiocardiogram, right? Or coronary angiogram, we call it coronary angiogram CAG. We are going to talk about all these three diagnostics, right? See, I teach cardiology to all of you, and a lot of people come and attend the classes, but this is the first time when we will be not talking about all myocardial infarction, or will not be talking about the myocardial infarction only definition types and all, like no theory here. As this is the demo class of our upcoming clinical diagnostic module 2, we'll be focusing only on the radiography part and all. As you must have seen that our browser, and we have recently closed the registration for clinical diagnostic course, master's course part 2. And amazing response as always. So I want to thank you all for that also. And let's see what we are going to do today and what we are going to cover in the upcoming course, right? So just let me take a minute to share this with you. This is our upcoming course. So master certificate course in clinical diagnostics. Okay, I'll be relating why and what we are covering today. So master certificate course in clinical diagnostics for clinical pharmacist. So this time, last time we have covered all cardiology also, but the biomarkers. Last time we have focused only on biomarkers of cancer, infectious diseases, and liver, kidney, cardiovascular. All biomarkers we discussed in last time, last module 1. This time we are focusing on radiology, histopathology, and microbiology. Okay, I mean the specific upgrade test what we do in the second or third phase, right? When we go for the doctor or clinician. So first phase we do the biomarkers, blood tests and all, and then we upgrade to the next phase, that is radiology, histopathophysiciology, or microbiology. So in that, this module we are covering a lot of things, right? Real-time case scenarios, and we have recently finished, so you know that how we have covered and how wonderfully you guys have learned in 12 classes, and all of that we have covered, right? So in this class, guys, in this module we are going to cover basics of radiology and liver imaging. All the liver, pancreas, kidney imaging, chest x-rays, how to read the chest x-ray, how to see the chest x-ray, how to see the pancreas imaging, how to see the CT, MRI images, and ECG, echo. We are going to cover coronary angiogram, angiography for the myocardial infarction, and cath lab tests we do. We will be covering that. We'll be covering PT scan, PET scan. We'll be covering tissue biopsies. We'll be covering blood culture and urine culture, specific tests for specific diseases. And these are the second and third, what we say, the grade tests, after the person comes to the hospital, right? So we have recently, completed the last date. May 20 was the last date for this course, and we got amazing response, right? So this is a kind of demo class today where I'll be covering ECG, echo, and coronary angiography, not in detail, just basics in 1 hour. Okay, so I'll try as much as I can tell you, but this is not the class from the course. Okay, but I'll be taking you through the basics and the overview of these three things. I'll be giving you what we should do, how we should do, and how these things happen, and what exactly are these things, right? And what are the uses and importance of these three tests: ECG, echo, and coronary angiography, right? And how exactly we measure the things, and what are the things we measure in these two things. Okay, so guys, I missed this throughout the oncology is next one and didn't register. Can we still register clinical diagnostics? Yeah, so I'm coming to that. So as this is the this webinar today is the demo class. Demo class means whoever missed the chance, only for today, only for today, we will be opening the admissions again. Okay, so you all can avail the admissions. Maybe by tonight you can register for this course. With the same price. We are not like increasing the prices at the last moment or something. You can just pay 299 and register for the module 2. And I am getting, and this course, guys, one more very important thing about this course is university affiliated. Okay, this course is university affiliated. This course is affiliated by Geetanjali University, Udaipur. Okay, this course is affiliated by Gitanjali University, Udaipur. So the certificate will be given by Climed Academy and Gitanjali University, Udaipur, both in combination. Okay, and will be signed by these. So if you are intern, definitely your attendance is there. Okay, so yes guys, so the thing is, now I'll tell you, so we are not increasing the fees and all, because I want you to get some more chances as well. Okay, so we are not charging extra at all. We are just charging 299 whatever is the fees, and this is like if you have missed the chance. So these two classes, today and tomorrow, will be like, one is for the demo class for our diagnostic course, and tomorrow it will be the the course which we are going to start on 2nd June. Again, that is master's course in oncology. Okay, tomorrow's class will be on that, right? So let's start, let's not wait much. And I'll be sharing the link in your group. I'll be sharing the, my team will be sharing the link in the emails as well. And at the end of webinar, you will be getting a feedback form for the certificates. Okay, because this webinar is certificate webinar. Okay, so you will be getting the certificate attendance form at the end, that is the feedback form as well. So in that, you can just fill the feedback form and you can get the attendance and certificate both, right? And I'll be sharing the link for this course as well. So stay with me here and let's start. Let's not wait much, guys, because we are already 14 minutes late. So thank you all again to be here. And all the people who are in the YouTube, I can see there are a lot of people, I think. Yeah, so there are a lot of people in the YouTube as well, guys. Thank you very much for joining through the YouTube as well. So let me share the PPTs. Okay, so guys, let me share the PPTs. Here are the PPTs. Yes. So let me take the class. So this will not be, a PPT based, complete PPT based class, or this will not be, like I'm only teaching. I will be discussing a lot of things with you, and I'll be, taking you through my experiences, and I'll be asking a lot of questions from your experience. Okay. So guys, I'll tell my team to just open your mics so you can interact with me. I hope you will not be disturbing in between, right? You all will be keeping your mics off until and unless you are not speaking. If you're not speaking, you have to keep your mics off. Otherwise, then if I ask the questions, you can just ask me. Okay, and you can just give the answers. So I'll start with the questions, guys. ECG, echo, and coronary angiography basics. MI diagnosis, we go for. So disclaimer, this is just like I have used a case report to start the case. Recently, I've discussed that case in the last MI class also, but that's not, this is just a base to discuss the, ECG, angio, and echo, but not complete thing, right? So let's start. Today, we are going to start with the case presentation, then diagnosis. Diagnosis means all the ECG, echo, and angiogram and diagnostic tips also I'm going to give you at the end, right, guys? So let's start. So tell me one thing, guys. This is a very basic question, very basic question. Okay, I mean, this case is definitely the myocardial infarction case, as we are discussing the myocardial infarction. So no use of asking this question, what will be the diagnosis to this patient. But my question here is if someone comes to the emergency room. Okay, I hope guys, can I know my audience, like which class do you study right now? I mean, which class and year? B Farm, M Farm, Farm D, MBBS, or whatever. You please write here so I could, understand dental, whatever. Okay, so please tell me whatever you are studying right now so I can understand my, audience better. Okay, so most of the people are cardiac pharmacotech technology are there. Wonderful. Cardiac care technology is there. Okay, great. Okay, cardiac care technology. Wonderful. I can see cardiac technology, third year, fourth year. Wonderful, wonderful, guys. I am very happy. Okay, farm Ds are more, B farms are more. Okay, okay. Medical lab science. Yes, wonderful, guys. Wonderful. That's great. Okay, so thank you, guys. So I hope you'll be knowing, at least the basics. So my question here is, I'll start with the basic question. Okay, so I'll be taking this class for at least 90 minutes. So you guys have to delay your dinner a bit, right? We'll be finishing by 8:45 or around 9. Maybe it's fine, I think, right? So one is here, senior cardiac technician Ankit. Yes. So let's ask let me ask the questions, not you, right? So guys, here is the very simple question, right? One patient, like whatever you say, like male 52, comes to the emergency room with severe chest pain, okay, radiating to left jaw and arm, okay, for last 2 hours, last 2 hours only, okay, last 2 hours only. Patient is hypertensive and diabetes and smoker and alcoholic, okay, and having the family history of MI. Father died at the age of suppose 50 years, right? You have the history, everything you have with you. So my first question with with this case report is, first, what is the diagnosis of this case? I mean, no, everyone knows this, okay? What is the diagnosis of this case? Angina.
Sir.
Angina. Okay, someone's mic is on. Please put off your mics, guys. Otherwise, I have to. I think everyone can answer in the chat box. So I'll just put off the mics. Everyone, kindly, my team, please put off the mics. Yeah. Okay, guys. Now no one can speak, so don't try to speak. Okay, but you guys can. Right. Angina. Is it angina? Is it angina? Okay, angina. Angina. Okay, angina is the symptom, guys. Okay, angina is not the disease. First of all, angina is the symptom. Okay, guys, listen to me carefully. Here, the people get a lot of confusion. Angina is a symptom. When it is unstable angina, stable angina means that is the stable chest pain or unstable chest pain. Okay, that is not the myocardial infarction until and unless there is the infraction or the solid proof, right? Solid proof, right? Solid proof like echocardiogram or ECG or angiogram or the troponin T or troponin I very high. Okay, I think I'm answering the question, my question. So this is the CAD. Maybe this is the suspected CAD. I can say this is not even, I mean, this is the suspected CAD. Okay, suspected CAD case. So I will not keep this like at the end of this. Now I'll keep like, okay, let me, take some other color so we can understand it better. So I'll keep it like this. I'll keep it like this. This is a coronary angiogram, I mean coronary artery disease. Okay, this is the coronary artery disease. Okay, more precisely, if I say this looks like ACS. What is ACS, guys? This looks like ACS. Yes, this looks like ACS. ACS is acute coronary syndrome. Acute coronary syndrome. Why? Because the patient is more prone. Patient has getting the score, like he is hypertensive. He has all the risk factors, including family history, and his angina or chest pain is radiating to the left jaw and left arm, which is the typical symptom of myocardial infarction, which is the typical symptom of ACS. Okay, now let me tell you one more very basic thing. His troponin T. We did the troponin T. Okay, troponin T came 0.82 nanogram per ml, right? Nanogram per ml. So what does it mean by, guys? What does it mean by this? If the troponin says that the level of troponin is 0.82 ng per ml. So what does it mean by? What do you think what it is? Okay, what do you think what it is, guys? Tell me. Positive. Okay, okay, very nice. Let me start the YouTube in another system because I cannot see here. Okay, yeah, please tell me, guys, more. MI, myocardial infarction. Okay, perfectly fine. Okay, anything else? Anything else, guys? Okay. Positive. Okay, okay, very nice. 1 second. Let me start the YouTube. Oh, yeah. Okay, so I can now see the YouTube comments also. I can see the YouTube comments also here. Wonderful. That's great. Okay. Okay, how to start the comments here? One sec, guys. Yes. Okay. Yes, perfectly fine. I can see now in the YouTube comments also. It is not myocarditis. Who is saying myocarditis? Toha myocarditis. How it is could be myocarditis? Okay, I'll come to the troponin T also. Okay, so troponin I is more preferred, more cardiac specific than troponin T, right? Okay, elevated troponin indicates a lot of things to discuss. And biomarkers we have discussed in last time, right? In cardio, I mean in the diagnostic part one, isn't it? Okay, 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 okay. Lot of questions, then more than answers. There are the questions. More than questions, there are the. More than answers, there are the questions. Okay, so let me first take these questions. Okay, first let me take these questions, then we will discuss further on the things, right? So first thing I'm getting the question here is what is troponin T? What is troponin? Okay, let me take you to the troponin just briefly. Okay, what is troponin? So troponin is the cardiac biomarker. Okay, troponin is the cardiac biomarker. So before we go to the troponin, let's understand how the myocardial infarction happened. So myocardial infarction happened when there is the injury in coronary artery. Okay, there is the injury in coronary artery, and due to the injury there is the secretion at the site of injury in coronary artery. Coronary artery means the vessels in the heart, the blood vessels in the heart, like which supplies the blood to the heart walls and different chambers, and the septum of the septum inside the heart. So these capillaries, these coronary arteries supplies the blood and nutritions to the heart. Okay, so what happens is usually sometimes these coronary arteries get injured. Okay, these get injured because of maybe things like many things are there, because of foreign particles, calcium particles, fat particles, or because of some catheters or anything toxic components. It could be anything. Okay, so when these arteries get injured inside, so what happens is there is a secretion of multiple things. Okay, multiple factors, like maybe the coagulation factors are there, and then there is a von Willebrand factor, and GP23 3b, and glycoproteins are there, and collagen is there. Multiple things are getting secreted from that place, okay, from the injury side. But what happens is when these things come out, GP23b a, right, GP2b3a, so and the von Willebrand factor. So what happens is at the injury side there is a circulation also in the capillary, there is the blood circulation, right? So what exactly happens is this: the secretions like the von Willebrand factor and GP2b3a, they attract the platelets. Okay, they attract the platelets, and then platelets come to that place and they attach with these factors, because platelets have the receptors for these factors: von Willebrand factor, GP2 to GP23 factors, GP2b3 factors. And then there are the receptors for what? Like, let me write here: von Willebrand factors. Okay, VWF. Okay, right. And then what is that? GP2b3a factor, glycoproteins and collagen. Okay, let me write. These three things are there, and platelets have von Willebrand factors, and platelets have the receptors for these. So these all things get attached to the platelets, and then what happens is platelet get attached to the injury to heal it. Okay, all platelets. That is the task of the platelets, right? That is the role of the platelets to heal the injured site, isn't it? So the platelets comes to that side and they try to heal it, and they attract more platelets to that side, right? And when there is more platelets, the site gets a little hump type of thing, like this is, if I say this is the coronary artery, right? This is the injury site, this is the injury site. All the platelets in the things, they're coming here and aggregating. So this is the hump. This hump is nothing but called as plaque. Okay, when it becomes the plaque, when there are the platelets, and along with platelets the calcium particles, dead red blood cells, I mean dead RBCs and other toxins, calcium, fat particles, multiple things comes to in. And the if I told you initially, there are the coagulation, factors also, right? This is the coagulation cascade also happens here. So there are the coagulation factors also. So the coagulation factors at the end, they made fibrin, and fibrin strengthen this plaque. Fibrin strengthen this plaque, right? So this plaque is nothing but the block, we say, right? In the normal language, in the layman language, we call it, there is the block in the heart artery, block in the artery, right? Block in the artery, and that is called the heart attack. That is called the heart attack. Why it is causing the heart attack? Why it is causing the myocardial infarction? Myocardial infarction is the injury in coronary artery. Okay, injury in coronary artery, which has made the plaque, and that plaque is restricting, what plaque is restricting? The blood flow. Plaque is restricting the blood flow, and this blood flow is like carrying the oxygen. So in the heart, there is the less supply of the oxygen right now, because of this plaque, less oxygen supply. And due to that, due to the the less oxygen supply, what happens is, there are the functions of the heart, like the contraction and relaxation, right? To pump the blood out of the heart to the lungs and to the body. So what happens is, when there is this plaque, this plaque stops, or this plaques, these plaques, like one plaque or multiple plaques, this plaque, what happens is, this stops or prevent, okay, either complete or partial blood flow. And what happens is, in the heart, after that, there is less supply and more demand of the oxygen to contract and relax the heart, to maintain the functions of the heart. And when it does not happen, patients usually die. Okay, patients usually die. So that is the process of heart attack or myocardial infarction. In brief, I'm telling, just in brief, otherwise we can take with the diagrams, a lot of things are there. So this entire process has three steps. First is platelet aggregation. Okay, platelet activation. It starts with the platelet activation. Let me write here. First thing is, first thing is uh, platelet activation happens when there is the injury in the vessel. Okay, then platelet aggregation. Okay, aggregation means when there is one or two platelets or 10 platelets or 100 platelets. I mean, this is not in 100, but when the 1,000 platelets get attached to the injury, another platelets also come and join that platelet aggregation. Aggregation and adhesion. Adhesion means these comes in the contact with fibrinogen and fibrin, and these make the clot at the end. These make the clot or plaque at the end. Okay, that is the whole process of heart attack. Now what happens is, when there is the injury, someone asked me about the troponin, right? What is troponin? So when there is the injury, from the injury site, there are multiple other things which are secreting. So biomarkers, when there is the injury, the troponin troponin also gets secreted. Okay, troponin also gets secreted, and the level of troponin. I mean, exact troponin is not secreting. I'll tell you the entire process. There's a plasminogen and multiple other things which actually gets activated and converted into the troponin. Okay, and two types of troponin, usually troponin I and troponin. No, not only two types, so there are 3-4 types of troponin. I can tell you better in the class, right? So the from the injury site, you can understand right now in the layman language, the troponin comes from the injury site. Okay, and level of troponins increases in the blood. Okay, increases in the blood. The best time to take the troponin T to understand the results is at least after 2 hours of injury. After 2 hours of injury, if you take if you get the heart attack, and within 2 hours, if you take the blood and test for the troponin, it doesn't come like increased or decreased, whatever, like it will not be increased, because it takes 2 hours to come to the actual circulation after the conversion of the multiple plasminogens and proteins into the troponin. Okay, that can be taken in the another class. But troponin is nothing but is a biomarker to detect the heart attack. This is the only typical biomarker. Only typical biomarker. What is biomarker? Like the laboratory investigations, biochemistry. Okay, if you have read of the biochemistry, this is the biochemical investigation, the laboratory investigation, which can be done through the blood test, which can be done through the simple blood test. So nowadays there are multiple types of troponins, and the test is very useful, and it can be done, guys. How easily it can be done now, let me tell you. It usually just take, sometimes it takes 5 minutes to 2 hours. How it is 5 minutes? If it is done bedside test can tell in 5 minutes. You can tell in 5 minutes. There are the kits of troponin I. Okay, so two types of troponin which are, like, are majorly used: troponin T and troponin I. Okay, troponin T and troponin I. So I'll tell you the difference also. But what happens is, it can be done bedside also. Troponin I has the advantage that it can be done bedside also, and it can show the results in 5 minutes. But troponin cannot be done bedside. Right now, we don't have the kits for troponin T. Okay, understand, guys, we don't have the kits for troponin T, and it can be done in the laboratory with the uses of big machines only. Okay, with the big machines, not in the kit, right? So now, what exactly the difference in which one is more sensitive? So troponin I and troponin T are not exactly the same thing. Okay, because there are the weight difference. Okay, first of all, the weight, molecular weight difference. Okay, molecular weight difference, and what we say them, amino acids chain. Amino acids chain, I mean, the molecular weight depends on the amino acid chain only. So amino acid chain is very important in the troponin T. So troponin T and troponin I, what's the difference accordingly? Troponin I is lighter, troponin T is lighter, T is heavier. Okay, T is heavier, I is lighter. And most importantly, when you comes to the clinical scenario, the sensitivity, troponin I sensitivity is just 60 to 80%. Okay, where troponin T sensitivity is around 75 to 95%. Understand that? So that's why troponin T is better than troponin I. Troponin I also can, detect the myocardial infarction. It also can detect the, heart attacks. But, and because it is easily available, that's why troponin I is used everywhere. Okay, because it is easily available, that's why troponin I is used everywhere. Otherwise, troponin T has the higher sensitivity. And if you go to any tertiary care center, or if you go to the uh, you know uh, secondary centers, you will get troponin T only done. In the primary care centers or in the, localized areas, you will not get the troponin T. You will get troponin I only. That's why troponin I is quite famous and, easily available and easily done. Okay, that is the major reason. So troponin I may have the, yes, it has the high, half life, but it doesn't matter when the sensitivity comes. It doesn't matter, because troponin I has the lesser sensitivity and quietly significant lesser, sensitivity than the troponin T. Okay, but that was not our major question, guys. We stuck somewhere else. Today's class was not on the troponin T, but that's okay. I mean, you got the basics. I mean, many people, you don't know the basics, right? So my question was, the patient got myocardial infarction now, right? I mean, according to us, myocardial infarction was there. And guys, let me tell you one more thing. What we forgot to discuss is troponin T levels. Okay, so we are discussing troponin T levels. The patient had 0.85, right? So this is elevated. This is elevated. This is elevated. So if it is elevated, then what is the, sorry, oh, I was changing the pen color. Okay, so 0.85, if it is elevated, Ng per ml. Okay, so if it is elevated, then what is the normal? See, normal is 0.01 according to multiple guidelines. According to guidelines, 0.01. If it is less than 0.01 ng per ml, that is, that is the normal thing. That is the normal thing, right? But what happens in clinical scenarios? Okay, in clinical scenarios, what we consider is, in clinical scenario, because it can increase to one, like 10 times, it can increase 10 folds just without any reason. Okay, maybe because of the little injury, or maybe because of the kidney functions, because of the, you know high efforts by the liver. Multiple things are there, guys, multiple things. So it can increase to 0.1 ng per ml. So clinically, we consider 0.1 ng per ml as the normal level of troponin T. Okay, 0.1 ng per ml we consider at the normal level of the troponin T, right? And if it is one sec, guys. Yes, guys, I'm sorry. Someone was on the door. Okay, no worries. So, when it comes to the clinical side, we consider up to 0.1 ng per ml as the normal, level. According to guidelines, this is the normal. Okay, according to clinical scenario, this is the normal. But when it comes to this patient, it is very, very high. It is normal to 85%, you know, high, 850% actually, if I say 850% higher than this, right? So it is very, very high in this scenario. Okay, so this case is confirmed to have the myocardial infarction. This case is confirmed to have the myocardial infarction with the biomarker, right? With the biomarker, subjective and objective evidences, correct? I mean, sign and symptoms and history and everything, biomarker says this patient is MI. But now my question to you is, after this all discussion, after the discussion of almost 25 minutes, now tell me what should be my next course of action. Next course of action to this patient. Yes, guys. In regards to diagnosis, in regards to diagnosis only, we are talking about diagnosis, right? In regards to diagnosis, what should be the next action? ECG, echo, ECG, echo, ECG, echo. I'm not asking the treatment, guys. No, don't tell me the treatments. No, don't confuse. We are not talking this. We're not discussing. Okay, so people are telling about ECG, echo, and stress test if needed. Mohit Sharma, stress test. Okay, I'll be talking about the stress test also. My next question will come to you. Angiography, ECG, echo. Perfect, perfect. You guys can answer it easily. Okay. So next thing is what we are going to do is first is ECG, then echo, and then based on that CAG is confirmed. If the troponin T is very high, we can just check ECG and then we can go for CAG. Okay, now my question is, as Mohit Sharma here has written, the stress test. Okay, guys, stress test. Considering this patient MI, ACS, someone has suggested stress test. Stress test. Now I am asking all of you, it should be done or not? I will ask something else. If it is reasonable right now or not. Stress test. Stress test is indicated because it is a stable angina. Wow. Who told that it is a stable angina? First of all. Okay, stable angina indicated. So Ambika is telling this is not required right now. Okay, fantastic. It is not required. Everyone is telling it is not required. It shouldn't be done in unstable angina. Okay, 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 guys. So everyone is telling it is risky or it should not be done. Okay, Vaishnavi is telling cardiac pro BNP test. Why pro BNP test now? Someone is asking me. I'll take all the queries. I'll ask you the questions from you only. Pro BNP. Yes, guys. So for all the information, let me tell you what is BNP. People even don't know troponin C, so they might be get scared after this name. So let me tell you guys, this is anti pro BNP. Okay, so anti pro BNP is nothing but this is the proactive part of BNP. And what is BNP? BNP is nothing but brain natriuretic peptide. Okay, brain natriuretic peptide, and this is the biomarker for heart failure, not heart attack, right, guys? This is the biomarker for heart failure, not heart attack. Okay, okay, this is the biomarker for heart failure, not the heart attack. And NT is nothing but natriuretic. I mean, the N terminal here. NT is N terminal. natriuretic peptide and terminal natriuretic peptide. Okay, so now let's not discuss anti-proBNP, but my question is if the stress test is reasonable or not. You guys told no. Yes, it is not at all reasonable. Why it is not reasonable is because the patient is already in ACS and patient has all the indications, or if I say the risk, and not the indications, if I say the subjective and objective evidences to confirm MI, right? And if it is ACS, then you should not go for stress test, because stress test can lead to further deterioration, like the pulmonary edema or the pulmonary burst, or multiple other things. Only stress test is indicated in, as someone Ambika has written, in stable angina. Stable angina. If this is stable angina and troponin T is not positive, ECG is not positive, then we go for the stress test, either stress echo or treadmill test. Okay, treadmill test, TMT, right? So at such time, we don't want the stress test. What is the process of stress test? See, stress test is nothing. Stress test is nothing but, let me tell you a little bit, okay? Little bit. Today we are not covering everything. Everything we'll cover in the classes, okay? So stress test is nothing but like either it is ECG or echo. Okay, either it is ECG or echo. I mean, it functions the same. If we are measuring the ECG normally, that means we are taking in the resting phase. ECG usually we take in the resting phase, guys. Focus. ECG we usually do in the resting phase. But when it comes to the stress test, we do the same ECG when the patient is exercising. When the patient is exercising means he will be running on the TMT in 1 to 3 phases. Okay, where he will be facing the high speed. I mean, his speed will be increased like this, his elevation will be increased like this on the treadmill. Okay, he will be running on the treadmill in 3 phases, and with the elevation and higher speed, and that time we measure the ECG. Okay, so during the exercise and activity, we measure the ECG. That is called stress test. When we are stressing the patient, usually what happens is in stable angina, patient gets angina when he is working, when he is in some activities, either running, exercising, working in the fields, anything it could be. Okay, when the patient is working, and when the patient takes the rest, angina goes away. Angina goes away. Okay, so that's why we need stress test. So echo is the same thing, but echo, how we will do echo when the patient is running? Not at all. What we do is stress echo is nothing but we give some chemicals. We give the dye to the patient, and not only the dye, but some stimulating agents. Okay, we give some stimulating agent, and due to that, the myocardium, or the myocardium is the wall of the heart, gets stimulated, and it gets the anxiety. If I say in the normal words, it gets the stress. Okay, and in such cases we do the echo, so it shows the defect or clot or whatever is there, it shows in the stress echo. Okay, it shows in the stress echo, right? That is the stress test. Now we'll go to the ECG echo and we'll do that, right? So here is the case what we are going to discuss, and I think I have discussed the similar thing. 39-year-old man presents to the emergency room with 8 to 10 substernal chest pain, pressure radiating to the left back for 9 hours. I told 2 hours, so it's 9 hours. His cousin died at the age of 46 years. MI after 1 year of angioplasty LOD, right? He is on lipid lowering agents and bisoprolol for past 8 months. So I'll not ask you, I'll write the patient is hypertensive, and patient also had the hyperlipidemia. Because he is taking lipid lowering agents, and bisoprolol he is taking for hypertension. He has the history of family history of MI. His cousin means the is the like the first relation blood. Okay, cousin means the first relation blood. Okay, first relation blood. Yeah, dobutamine stress echo. Yes, dobutamine we give to stress the heart. Dobutamine. Okay, we give dobutamine. Okay, someone can tell me what is dobutamine? Dobutamine is what, guys? Dobutamine is what? inotrope. Dobutamine is one inotrope agent. This is the assignment for you, everyone. Please go and check what is inotropes. What is the work of inotropic agents? Okay, dobutamine is inotrope, and it works on the heart to stress it. Okay, so this patient has like the chest pain, subjective evidences, objective evidences, everything is there. And then what we did is we did, ECG, other tests we did, multiple other tests like serum creatinine was 1.3, and TG's total glycerides are 386, which are very high. It should be less than 200, right? LDL is 236. It should be less than 100 mg per dl. Okay, it should be less than 200 mg per dl. HbA1c, this patient is also having diabetes C, so HbA1c is 7.9. And see, look at this, CK and CKMB. CK is higher, CKMB is normal, troponin T is 0.88. Okay, anti-proBNP we did, it was 1090 pg per ml, but it could be, guys, let me tell you, it could be ischemic heart failure. Heart failure due to ischemia, not the heart failure, the not decompensated heart failure. Okay, or not the left ventricular failure or right ventricular failure. This is ischemia. Okay, this is because of the ischemia, so we call it ischemic heart failure. Okay, we call it ischemic heart failure, right? We call it ischemic heart failure, right? So yeah, vasopressor vasopressor inotropic agent is there. Okay, so now my next concern here is, if we, like, we did all the blood test and we did ECG. Okay, I'll come to my first topic of today's webinar. After almost 50 minutes, this is ECG. Okay, so look at the ECG, guys. What do you understand by ECG? I mean, you have read this ECG many times. You have read this ECG many times. How it is anterior MI pre-day? Please tell me why it is anterior wall MI. Can someone tell me why it is anterior wall MI? I'm not asking even anterior wall MI. What type of MI it is, guys? What type of MI this is? Can someone tell me? Yes, it can worsen the condition. Yes, guys. Yes. STEMI. Okay, ST elevation MI. Guys, you almost all, I taught this case few days back only. STEMI, really? Where is the ST elevation tech? Okay, where we see usually. Okay, let's look at second, lead second. I'll delete everything and let's see. I'll erase everything and let's see. This is the lead 2, lead 3. This is the 12 lead ECG first of all. 12 lead ECG, right? In this 1, 2, 3 lead, AVR, AVL, AVF, and then one V1, V2, V3, V4, V5, V6. So there are 12 leads. Okay. In this, if we look at the 2, where is the ST elevation? This is not ST elevation, but this is T inversion. T is going down. In the 3 also, T is going down, T inversion. In the 4, 5, and 6, if you look at the 5, this is ST depression. ST depression. ST is going down than baseline. Okay, look at this. This is the baseline. This is the baseline. And ST here. ST is going down. Here also look at this. Baseline is this. ST is going down. ST is like the distance between from S to T, right? ST segment. Okay, this is ST segment. I'll tell you about ECG entirely here. Today I brought many ECGs to teach you. Okay, so here look at this, guys. So ST is depressed niche. I mean, ST is going down. If you look at this here, you will see clearly ST is going down. Okay, here if you look at this, ST is going down. Right here, T inversion. So T inversion and ST depression are the signs of anstomy. Why it is anstomy? Because here ST is not elevated. Simple. There are two types of ACS. I mean, there is stable, unstable angina, STEMI, and STEMI. Three types of ACS is there, but the major is STEMI. I mean, according to ECG and anstomy. Okay. So what is STEMI? If the ST levels are elevated like this, ST is elevated like this. Okay. Focus on my cursor. ST pen, focus on my pen. ST is elevated like this. Okay, so then it is called ST elevation MI. ST elevation myocardial infarction. But if there is no elevation and there is depression of ST and this depression of T waves, like the inversion of T waves, that is called anstomy, because ST is not elevated. So this is just opposite. Okay, here ST is depressed, here T is inverted. So this is anstomy. This is anstomy. Let's understand more in the next slides. Let's understand what are the ECGs. Okay, so this case was MI. So this is the myocardial infarction. This is the normal blood flow, as I told you, and this is after the plaque, blocked coronary artery. This is the blocked coronary artery. So it has platelets, it has platelets, fat, calcium, dead RBCs, multiple particles, collagen factors, everything, collagen and coagulation factors, multiple things are there in this. Multiple things are there in this injury, and the blood flow, which was 100% here. If I say this is 100%, here it is just around 20 or 30%. Here it is just 20 or 30%, guys. Okay, 20 or 30%, right? So let's understand more what's the differences. So see, there are this is the major difference here. Stable angina, as we are talking about, I'll not I'll not take much time. Stable angina means when there is a normal plaque. This is the plaque. Okay, plaque can happen in the healthy person also. Plaque means, like, because not the injury. Okay, plaque means some because of anything, there is the accumulation of fat, calcium or anything, usually fat at the first site, the free fatty acids we call them. Okay, so these are accumulated here, but definitely due to this also, the blood circulation is compromised. The percentage of the blood is compromised, the circulation is compromised here. So what happens is, again here, demand is more and supply of the oxygen is less. So chest pain happens in certain cases. Chest pain happens, and that is called angina. Understand that this is angina. This is angina now. Okay, and this angina can be sometimes detected in the troponin, by the troponin I or troponin T, but sometimes it does not. Okay, even the ECGs are normal in case of stable angina. Okay, ECGs are normal in stable angina, right? So what we do is, we go for, if ECG is normal, if troponins are normal, then what we go for is stress test. Here we need the stress test, because the patient can get the alleviation of the symptoms at rest, right? At rest. But in the unstable angina, what happens is, this plaque is ruptured. This plaque is ruptured due to injury in the, at the site, due to injury. Sometimes here the ECG is showing the signs of myocardial infarction, sometimes not. Sometimes you get ECG normal, sometimes you get inverted T waves or ST depression. In this also, in unstable angina also, you will not get ST elevation, you will be getting ST depression or T wave inversion. Understand, guys? T wave inversion. And then again, here also, troponin T may or may not be raised. Troponin T may not be elevated. Again, here also, troponin T may or may not be raised in unstable angina. But when it comes to anstomy, these two are the massive heart attacks, we call it. Okay, massive heart attack. So what happens is, anstomy, why I'm telling anstomy before is because, again, it shows like there is complete infarction, and the patient can die anytime, like within 1 minute to, like, it can grow from 1% to 100% in the artery within minutes. Okay, anstomy or stomy, the plaque can grow within the artery within minutes. Okay, within minutes to hours. It is completely depending on the person's physiology, completely depending on the risk factors, completely depending on the like what we say, God's miracle. Okay, if you are getting anstomy or stomy, massive heart attacks, you are completely depending on the luck. Okay, so how fast it is increasing depending on your pathophysiology, depending on the physiology, right? So what happens here is, here you will get, again, ECG will not be normal. Okay, ECG will be showing the same thing, T wave inversion or ST depression. T wave inversion or ST depression. Okay, and that is called as non ST elevation MI, right? Now the fourth thing comes ST elevation. Similarly, I mean, the plaque can grow anytime, but here what happens is you will get hyperacute T wave or ST elevation. T elevation, see, T elevation. T is completely elevated, more than normal. T is completely elevated, upper side elevated, not inverted, elevated here. Okay, and complete ST segment is also elevated. Either T is hyperacutely elevated or ST elevation. T elevation or ST elevation will be seen in STEMI. Okay, seen in STEMI. ST elevation myocardial infarction. That's why we call it ST elevation myocardial infarction. Okay, and troponin T's will be troponin I or T will be elevated in this. So that's why we call these three as ACS. Okay, combinedly, guys, focus here is very important point. All four are called as CAD. All four are called as CAD because these all are coronary artery disease related to the coronary artery. Okay, but in these four, three are called as acute coronary syndrome because these can cause harm to the patient acutely, and these needs the attention, medical attention acutely, means immediately after happening the problem. These needs the you know like medical attention, right? This needs the medical attention immediate after happening. So that's why we call them acute coronary syndrome. So this is the electrocardiogram, guys. Simple. This is the normal electrocardiogram. Okay, this is the normal ECG. This is the normal ECG. If I say it starts with the P wave, it starts with the P wave. This is the P wave here, right? And then PR segment, like there's a little segment, little baseline between P wave and QRS segment, QRS complex. Okay, this is Q wave, this is R wave, this is S wave. Okay, this is S point, if we say precisely S point. Okay, so this entirely is called as QRS complex because here are three waves, Q, R, and S. Okay, this curve is like QRS, right? So P wave normal, this is looking normal. This is Q wave. I mean, this is the normal ECG, right? So QRS, ST segment. This is the ST segment. So ST segment, all segments are baselines. Okay, all segments are considered as baseline. And see what you have seen in STEMI or anstomy. In STEMI, ST elevation, it will be elevated like this. It will be elevated like this, right? In ST, like in anastomy, it will be inverted ST inversion. Okay, it will be inverted like this, right? Depressed, right? ST depression will be like that. So these are the major changes. Okay, these are the major changes in the ST elevations and non-ST elevation MIs, right? And then this is the T wave. So either T wave will be inverted or it will be elevated. So this is the normal T wave. Okay, elevated means it will be elevated like this, too much elevation. Okay, at least you know uh, two times higher than the normal. Okay, and if we call in the in the ECG sector, the ECG, when we see, that is counted in duration is counted in Okay, so it is the normal ECG. You can understand, first is P wave, then Q, R, S, T. Okay, and these are the segments between all the waves, PQR, PR segment, then ST segment, and then this is like total one, this is total one beat. Okay, this is the total one beat or rhythm. Rhythm is actually of the three beats, but this is one beat. Okay, this is the one beat. Okay, like one sort of the blood going out of the RV, going out of the LV. Okay, going out of the LV to the entire body. Understand, guys, here the LV. Okay, entire the blood will be going to the entire body from LV to aorta. Okay, and aorta to the entire body, and from the entire body, like from the aorta only, there is the capillary which brings the blood to the heart also, right? Brings the oxygenated blood to the heart also. Those are called as coronary arteries. Those are called as coronary arteries, right? So now, here is done. Let's not waste time. So here, what is the physiology? Actual ECG physiology. Okay, you might have not read it before, how to read the ECG. You can easily now identify the myocardial infarctions, but you are not the master definitely right now, but you can easily identify it. Okay, which waves indicate what, I'll take in class, because otherwise it will take a lot of time. It will take a lot of time. But usually here, the P wave shows the contraction. Contraction means, see, you might be knowing that blood from the body comes to the left atrium, and from left atrium it goes to the left sorry, it goes to comes to the right atrium and goes to the right ventricle, and from right ventricle it goes to the lungs, and from lungs it comes to the left atrium, and from left atrium it goes to the left ventricle, and from left ventricle, like, it goes to the aorta, and aorta to the body parts, right? Body parts, correct. This is the flow of, blood in the heart, right? This is the flow of blood in the heart, right? So what happens is, why and when, within a beat, how the blood, goes from which chamber to which chamber. So when it is a p wave, okay, in ECG, when the p wave comes, so how it comes exactly, I'll come to that also. I'll tell you what is the conduction system and how it works. Okay, to understand the ECG, you need to understand the conduction system. Okay, I'll tell about the conduction system also, a little bit about. If the troponin T is increased but the ECG and echocardiograms are normal, could it indicate ACS anastomia? It is not at all possible. First of all, if the troponin T is increased, but some cases, yeah, in some accidental injuries, it may be okay, it may be increased in the accidental injuries like blunt, injuries. Usually, sometimes it happens, but it is a very rare. Like if the troponin T is increased, so that's why I was telling you. Like that's why I was telling you when I was talking about troponin T. So 10 times higher, 10 folds higher than normal, we consider it maybe because of some other reason. 0.01 to zero point 0.1, okay, 0.01 to zero point 0.1, we consider it like it can be accidentally, okay, or we don't understand, or we don't consider it clinically significant. When it goes to point 0.01 to zero point 0.1, then it becomes the clinical significant, then it becomes the clinically significant high troponin T. Okay, then it becomes the clinically significant high troponin T. Okay. Okay. Why not 2D echo or stable angina? 2D echo for stable angina. Stable angina will not, tell you about the, it will not come in the 2D echo, because as the patient alleviates the angina during the rest, so even the cardiac functions comes to the normal. So echo will not help in even stable angina, right? Stress tests are needed, because in stress test only it shows the, dysfunctions of the heart, right? How long the class will last? I told initially only the class may go up to 9. Okay, 8:45, 9, right? So, guys, P wave shows the atrial depolarization, contraction. So, as I was telling, the blood comes to the right atrium, right? And the blood comes to left atrium. From where? Like it comes from the body, and it comes from the lungs, right? This is oxygenated blood, this is deoxygenated blood, right? So when it comes to the atrial depolarization, the P wave, the contraction, so in that case RA and LA, I mean the right atrium and left atrium are contracted. Okay, so the blood squeezes to the RV and LV. Okay, RV and LV. Understand? RV and LV parallelly, right? So now the blood is in RV and from LA to LV usually. And what happens is now in the next phase only, in the next phase, I mean, we are talking about longer, but it takes the milliseconds sometimes. Okay, it takes the milliseconds. So in next phases, what happens is when it goes to the PR segment, when it goes to the PR segment, so similarly, in this the PR segment, the next phase is very small. Very small means zero point 0.3 milliseconds, sometimes 0.3 to 0.6 milliseconds. So in this time, what happens is like RA or RV and LA and LV means both on the four chambers get relaxed, right? Get relaxed means like it is again the depolarization. The contraction to the, I mean, it comes from the contraction to the regular, what we say, the regular action, and from the regular action it goes to the relaxation. So this is the phase, like this is a very small phase where you can say all four chambers are coming to the regular phase, to coming to the normal. So here, the blood is going from RA to RV and LA to LV. okay, that captures in ECG as PR segment. Okay, and then immediately next phase started the QRS complex. QRS complex is ventricular depolarization. Ventricular depolarization means the ventricles will, contract and squeeze the blood out to the lungs and to the aorta. Like the RV will squeeze the blood to the lungs and LV will squeeze blood to the aorta, right? That is the next phase, and in that only this phase is quite longer because we have to push the complete blood to these chambers, like the lung or to the aorta, to the entire heart. So it is a quite longer phase. So here, like in the QRS, ventricular depolarization is, at the minimum. Okay, and it get extensive when it comes to the ST segment. So complete ventricle, depolarization happens, and then ventricular, repolarization start here. Okay, repolarization means the relaxation. So once the LV is squeezed at the QRS phase, I'm talking about the ECG here, guys. Okay, how the ECG and the beat or the heart functions, or the, contraction and relaxation works together. How we can correlate it? Okay, so the QRS will be, was kind of, the starting of ventricular, depolarization means the contraction, so the blood goes out of the ventricles. Okay, immediately ST segment starts, like when the, QRS completes and ST starts, that time, by the time the entire blood is in RV. Okay, I mean entire blood is almost out of the RV, right? Almost out of the RV, right? And now RVs are getting relaxed. Okay, so ST phase starts with the relaxation of, like, the ventricles, RV and LV both, with the relaxation of ventricles, right? And once this comes to the last phase, or the T wave in ECG, that is complete repolarization of the ventricles. The ventricles are completely relaxed here, means the entire blood has gone, and now these two sacs, like one is, RV and LV, are ready to receive the blood from the next beat, or like the, the cycle is going on, right? The cycle. So for the next cycle, these are ready to take the blood from RA and LA, right, atrium and left atrium, right? So this is the cycle, right? It starts from the P wave, like the contraction of RA and LA, blood goes to RV and LV, right? And then it, like, goes to the lungs, and from the RV, and from the LV it goes to the body in the QRS phase, ventricular depolarization, right? And then in ST and T wave, these ventricles are also completely relaxed. I hope you understand, guys. Yes. Okay. Okay. Great. So now we'll go to the next part. Now we'll go to the next part. Great. Now we'll go to the next part here. So the types of ECG, guys, because we have to understand the ECG completely. So there are three types of ECG. One is 3 leads, one is 5 leads, one is 12 leads standard. Okay, that is the standard ECG 12 lead. So guys, remember one thing. When we call about 3 leads ECG, there are 3 electrodes. Okay, so leads and electrodes are different. Okay, can someone tell me what is the difference between lead and electrodes? Can someone tell me what's the lead and what is the, yeah, what is the lead and what is the electrode? What is the difference between electrodes and leads? Can someone tell me? Yes. My next question to all of you is, how many wires? I'll write in a very layman language. Have you seen attached to human body in ECG 12 lead? How many wires have you seen attached to the human body in 12 lead ECG? Guys, tell me. 12? 10, 10, 10, 10, 10. Everyone. 10. Exactly. So, guys, the simple difference. I'll not take much time. I'll not ask you this question. So, ECG leads. Okay, when we talk about leads, leads is the representation. Representation of representation of impulses. in ECG graph paper. Okay, ECG graph paper. Leads means just the representation of cardiac impulses in the ECG graph paper. But usually to the body, the things which are attached to the body are called as electrodes. So there are only 10 electrodes in the highest ECG leads. Only the 10 electrodes are attached to the body, not 12. 12 leads will come on the paper only. Okay, only 10 electrodes will be attached to the body, right? But in the 3 lead ECG, 3 electrodes will be attached. 5 lead ECG, 5 electrodes will be attached to the body. But in 12 lead ECG, standard ECG, only 10 electrodes will be attached to the body. Only 10 electrodes. Okay, so let's go to the next slide. Okay, let's go to the next slide. So here, yeah. So here, let's understand the leads placement. There are 10 leads. Okay, there are 10 leads. So these are the all leads, like based on the color, like V1 red. Okay, right, V1 red is attached to the external is right fourth ICS. That I'll come back later. Okay, so let's see here first. Let's see here first. Okay, so these are the colors of the your leads. These are the limb leads. Okay, these four are the limb leads which are attached to your upper limb and lower limb, like hands and legs. Okay, hands and legs. These four are attached to the hands and legs. If these are not the types of leads, sometimes we don't put on the hands here, see here, or at the legs, downside of the legs, like near to the ankle. We don't attach. Sometimes we have the attached, attachable leads. So we keep all of them on the chest only. Okay, no need to keep on the limb. So we keep it near to the shoulder and near to the shoulders and near to the thighs. Okay, on the stomach. Okay, if not having this kind of clips, we have the simple leads like this, and those can be attached near to the thighs and near to the shoulders. Okay, I'll show them to you. Leads are, as I just told, leads are nothing but the representation of the impulses on the ECG graph. Okay, so we call them, these are the electrodes. Actually, these are the electrodes, not leads. We call them leads only. I mean, we don't discriminate with these things. But okay, I'll repeat it again. See, these are, I'll make it very clear for you guys, otherwise you will be not understanding. So these are not leads, let me tell you. These are the placements of electrodes. Okay, electrodes. These are the placements of electrodes. So these four electrodes, as you can see by the shape, these are attached to the hands and legs. Limb leads, we call them, I mean, limb electrodes, if I say in the language. Otherwise, these are called as limb leads, limb electrodes. Okay, these are the chest electrodes, chest leads or chest electrodes. These are attached to the chest. Okay, so these are colors. These are the different colors. Okay, these are the different colors: black, green, red, yellow, and these are the different colors here again. So how it is attached? How these are attached to the human body? Okay, why 10 electrodes for 12 leads? Okay, so leads are different thing, guys. Leads are just the representation, because there are three leads, not two leads. There are three leads which are the mirror images. Okay, AVF, AVL are the mirror images of lead A and lead 1 and lead 2. Okay, these are the mirror images. Okay, these are the mirror images. That's why we just need 10 electrodes for 12 leads. That's why we need 10 electrodes for 12 leads. Sir, you are not audible to me. Please check your networks, Manal. Okay. So no, I'm telling you, don't justify. Maybe we only have 10 attachment points. No. It's not about that. Like, there are two leads. When we come to the graph for the precision, uh, listen carefully, guys. For the precision results, for the precise results, definite results with high sensitivity, there are three leads which are mimicking or the mirror images of other three leads. Okay, like the AVL, AVF, and I'll show you the lateral leads. Lateral leads are the mirror images of lead 1, 2, and 3. Okay, right? So that's why on the paper there are 12 leads, but to attach, which are gathering or catching the impulses from the body, we need only 10 electrodes. Okay, that's why this is the difference. Not like we have only 10 attachment points. No, 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 no. This is not the logic. Okay, so we have, when all the electrodes gets the impulses, those are converted into the leads, okay, on the paper, right? Just for the representation purpose. Okay, so here, look at this, how these are attached, so like, let's understand the, like, this is the basic thing, like, this is the external area, full external area. So look at this here, like, rib 1 2 3 4 5 6 7 8 9 10, right? So how do we attach v4? V4 will be attached complete, to the mid clavicular line. This is the mid clavicular line. Okay, this is the mid clavicular line. So V4 is attached to the mid clavicular line, and V5 is next to the clavicular line, that is anterior axillary line, and then mid axillary line. Mid axis means if you cut it vertically, okay, but in the standing position vertically, it can be like, definitely it will be vertical, either you cut from the front or side. So axillary is the side line. Okay, axillary is the side line, clavicular is the frontal line of the heart. Okay, frontal line of the heart. So when it is anterior side of the axillary, we put V5. Okay, and at the mid axillary line we put this V6, and this is the anatomy. There's nothing else to understand here. This is the anatomy here. Okay, and like, these are the what we these are the ribs. Okay, these are the ribs. Okay, so this is the external cage. We completely, I mean, this entire image is known as external cage. Okay, or we call it rib cage. Okay, rib cage or external cage. Understand, guys? It's very simple to understand. Okay, yeah, I'll come to the dextrocardia also. So mid clavicular line is this. Okay, so mid clavicular line we put V4, and then V5 anterior axillary line, and mid axillary line V6. Okay, and just opposite to that in the left side, I mean in the right side, just opposite to that, this is the left side, this is the left side, this is the right side. Okay, so just opposite to that in the right side, what we put is V7, sorry, V7, V8, V9. Like, okay, mirror, just mirror. Okay, just like you have to copy that from this side to this side. Right side, mid clavicular line is V9, V7, and then anterior axillary, like it is, the V8, and then mid axillary, it is V9. Okay, like these are the leads what we attach usually. Okay, and then I'll show you that. I'll show you the complete thing. Okay, and this is the, like, external case, and we can understand it how we keep these, like, and where we keep V3, V4, V5, and V6. Why we are showing just these three here? These three are the important leads, guys. These three are the important leads, because here are the highest impulses at our chest. Okay, in at our chest, like on our chest, that this is the region where we get the highest impulses from the heart, because this is just the mid point of the heart. Okay, below to the, I mean above to the apex, this is the midpoint of our heart. Okay, this is the midpoint of our heart, and the highest frequency of the impulses we get only here. Okay, we get only here, right? V is nothing but the lead names. Okay, lead names. Now let's understand more efficiently here. Look at this, guys. Okay, look at this. So as I was telling, if you don't put here, usually we put here the wrist, I mean wrist, or maybe at the ankle side of the leg. If we're not putting that, you can just put on the stomach, right side lower, left leg, right leg. Okay, you can put here right leg, left leg. You can just put here in the original image, you can see left leg, right leg. Okay, then RA, right arm, left arm, right arm, left arm, right arm, left arm, right arm, left arm. Then V1, V2, V3, and V4, V5, V6. Mid axillary, the mid axillary, anterior axillary, mid clavicular. Okay, this is mid clavicular, anterior axillary, mid axillary. Okay, mid axillary. So in dextrocardia, as I was telling, it is just copy. Okay, like V4, V5, V6 will be this side. Okay, in the dextrocardia, V4, V5, V6 will be this side. Understand? I was telling the mirror image. So these V4, V5, V6 will be at the opposite side, okay, for the dextrocardia augmentin leads, right? So these are the major things how you place the leads. Okay. Now with the colors, if I tell you the colors, see, these are the colors given here. These are the colors given here. Like if you don't know which leads to put where, so just follow the colors, right? Left arm will be black, left leg will be red fire, right leg will be green class, I mean green like grass, okay, and then right arm will be white, okay, like white snow. Okay, so you can see here, this will be put on right arm, this will be put on left arm, like the black, white and black are for arms, red and green are for legs, red for left leg, green for right leg. Okay, then v1 v2 v6, like v1 to v6, like v1 is again red, the external case fourth ics, then left for right fourth ics, left fourth ics, like yellow color, and then green color between v2 and v4, then v4 v5 v6, I mean v3, I mean v4 v5 v6 are midclavicular between v4 and v6, like ics, and anterior axillary and then mid axillary. Okay, anterior axillary and mid axillary. So this is orange one, purple one, blue one, green one, yellow one, red one. Okay, so these are the different types of leads or different types of electrodes, and these are different types of electrodes, so you can easily understand by the color which one to put where. Right now you understand, these are the colors right here, these are the colors here. Okay, so wire colors here, you will get the wire colors here. Okay, not these colors, sometimes these colors are same, but wire colors which are coming, you can easily understand by. And these are like, this is white, okay, this is red, green, black. Okay, white or yellow, sometimes it's yellow, sometimes white, so in this depicts the red. Now 3 leads ECG, there are only 3 leads, one will be put on right arm, and one will put on left arm, one will put on left leg. Okay, so now these can detect the balanced, balanced is sternum, mid sternum, this is the mid sternum. So from the mid sternum the distance should be same. Okay, distance must be same for all 3 leads, so all 3 leads gather the impulses completely at the similar directions and similar frequency. In the 3 leads we need only 3 leads, one is ra, one is la, one is ll. Okay, left leg, we don't need 5 legs, we don't need 5 leads or 10 leads, I mean the 10 electrodes or 5 electrodes, why we don't need? And where the 3 lead eco, I mean 3 lead ECG is being used, guys, can someone tell me where the 3 lead ECG is being used? Yes guys, where the 3 lead ECG is being used? ICU, yes. 3 lead ECG or 5 lead ECGs are being used in ICUs and in the pocket ECGs, where in like primary care centers, or when we are going to the community, we need the 3 lead or 5 lead ECGs. Okay, or in ICUs, we need 3 lead or 5 lead ECGs. We don't need the 12 lead ECGs. Okay, so in the ECG monitorings, because the patient is already incumbent and there are many things attached, like maybe you have the uh, uh, the incubation, or you have the capillaries and maybe the Rales tube or whatever, and injections and multiple things are there, right? So we need minimum coverage of the body, so we need just 3 lead or 5 leads in the intensive care units. Okay, so this is the 3 lead ECG. 3 lead ECG is usually there, and this is how it leads, how it looks like. So lead 1, lead 2, lead 3, there is no AVF, AVL, and v1, v2, v3, v4, v6, no, there is only 1 and 2 or 3 leads. Okay, and then similar to 5 lead ECG, 5 lead ECG again, there are 5 lead ECG again, like the sternum, this is the mid sternum, so we just keep one V, okay, near to sternum, and then at the same distance RA, LA, RL, LL, left leg, right leg, left arm, right arm. Okay, we put our ECG electrodes here, and then we get the 5 electrode ECG. So again, I'll not go into the deep. So this is the 5 lead ECG. 5 lead ECG also depicts the 12, sometimes 12 lead ECG type. Okay, it looks like the 12 lead ECG only. Okay, sometimes it looks like the 12 lead ECG only. Okay, but 5 leads, 5 electrodes. Sometimes it's like 1, 2, 3, AVR, AVL, AVR, AVL. I mean, it depends like where you are using it. Okay, if you are using in the pocket ECGs in the community, it will show the complete 12 leads. If it is in ICU or maybe the other settings, it will show only 5 leads. Sometimes 1, 2, 3 AVR, AVL, sometimes 1, 2, 3 V1, V2. Okay, so it depends completely what you want to see. Okay, it depends, but only 5 leads it is so. Sir, in case of differently abled persons with no limbs, where the limbs or leads electrode will be placed. As I told you, Abhinesh, this is very simple as I told you in this picture. Okay, in this picture, I showed you clearly in this picture. See, it is not put on arms. This is not on arms. As I told you, this is on the shoulders. This is near to the shoulders. Here, look at this. These are not the legs. These are on the stomach only, just at the starting point of thighs. Okay, this is a very simple answer to your question. Okay, now it comes to 12 lead ECG. So 12 lead ECG is more powerful, as we have seen, like where to put. Like this is the more powerful ECG and more sensitive, right? You can see this, like this is the normal one, right? This is the normal ECG. So 1, 2, 3, AVR, AVL, AVF, V22, I mean V12, V6. Okay, anterior posterior leads, I'll not tell you today. Explain the ECG. Dear, I'll explain in the class, because now we have to talk a little bit about echo and angiogram also. Okay. What is the full form of AVR, AVL, and AVF, guys? Tell me. These are anterior leads. Okay, and these are the mirror leads of these also. These are the mirror leads to the first 3 leads. Okay. So let's come to the ECG. Okay, let's come to the ECG. So we have discussed this. This is the normal segment. This is the ST depression. This is the anastomy, like again T inversion here. This is the T inversion. This is the ST elevation. Entire ST is elevated from the baseline. So normal, right? You can understand it easily. Augmented leads, but augmented vector right, vector left, yes, and augmented vector front. Okay, got it. Yeah. So cardiac conduction, I'll not go to this, but like it starts from the sinus, sinoatrial nodes. Sinoatrial node is called as the permanent pacemaker of heart. Okay, permanent pacemaker of heart. It generates the entire conduction system, like entire impulses, which goes to the AV node. AV is here atrioventricular node. Why we call it atrioventricular node? Because it is at the edge of, I mean, the septum of atrium and ventricular. That's why we call it atrioventricular node. So impulses are generated, guys, understand little. Impulses are generated from the sinoatrial node, SA node, which is the permanent, which is also known as permanent pacemaker of heart. And then it goes to the AV node, and from AV node, let me show you here. From AV node, through the bundle of His, it goes to the, from the bundle of His, it goes to the septum, atrioventricular septum. Atrioventricular septum means septum, this is the atrioventricular septum, and through the atrioventricular septum it goes to the septum which separates the left atrium and right. I'm so sorry, guys, this is the ventricle, not atrium. Let me write again. So this is, so here this is right, oh god, this is what is happening in my pen here? Yeah, this is right atrium, this is left atrium, this is right ventricle, this is left ventricle. Okay, this is left ventricle, right? Left atrium, right atrium. So usually the impulses are from SA node in right atrium, goes to the AV node in at the septum of RA and RV. Okay, RA and RV, like atrioventricular nodes we call this. And then through the septum it goes to the septum between ventricles, RV and LV. Okay, here it is where the branches are called as right and left bundle branches, and it goes to the wall of the heart. In wall of the heart it again divides into the small branches. Those small branches are called as Purkinje's fibers. Okay, that's how the impulses run in the heart and control the contraction and relaxation of the heart, and that only leads to the beat, that only leads to the functions of the heart. Okay, so let's not discuss this here. Now I'll come to the echocardiography. How to read ECG in case of patient suffering from WPW syndrome, Wolff-Parkinson syndrome. Again, is like I'm not discussing the ECG completely now, guys, because this class is a demo class, right? And ECG, echo, and TMTs. I mean TMT and coronary angiogram will be completely discussed in one classes. Okay, so you can join the course and you can definitely get the full coverage, right? But I'm here to tell you the basics. Okay, so this is about echocardiogram. So see, look at this, guys. What this person is doing, this person is performing echocardiogram to this person, this patient. This is the patient, this is the doctor or echo technician. Okay, echo technician, right? Echo technician or doctor, it could be. It is performing the echo in this person. And what is this? What is this he is handling, guys? What is this he is handling? What is this person handling? This little part of the, which is attached to the wire, which is attached to the wire, is called as probe. Okay, probe. This is called as probe. Yes, transducer or probe, right? We call it transducer or probe. So can someone tell me, can someone has courage to tell me what is the exact, what is the exact mechanism of echo, how the echo works? I mean, it's, see, we can see here very clearly the person is putting transducer or probe, right, on the patient's chest, and you can see the picture inside the heart, right? You can see the heart from inside, isn't it? Not from the outside. We can see the heart from the inside. So what is the functional mechanism of, what is the functional mechanism of echocardiogram? Can someone tell me how it works? Yes, detects the blood flow by echo sound produced by the echo probe. Ultrasound, absolutely, Hima, Ankit. This is the echo sound. This is completely on the ultrasound. The sounds, it takes the ultrasound, I mean the sounds from the heart, flow of the blood, and based on that, it depicts the picture inside, I mean picture here on the screen. Okay, this is nothing but the ultrasound. Okay, it captures the sound, and based on the sound, it creates the image. This is not the real image of the heart, understand? This is not the real image of the heart, but this is just the, based on the ultrasound, it just, this is not the camera inside the probe. Okay, understand, guys? There is no camera inside the probe, like, which shows the entire heart from the inside. Okay, otherwise it will be so, it will be showing the muscles, it will be showing the red blood, everything. But no, this is just the sound. It captures the sound from the blood inside the heart, and based on that, it depicts the picture on the screen. Okay, it is ultrasound based. It is completely ultrasound based. Okay, sonography and see, ultrasonography, ultrasound are the same system, but used for the different mechanisms, and has a little more, significant, what we say, the efficiencies, and a little more, what we say are, I forgot the word. I mean, we can say that is like uh, customized part, right? Ultrasound like the basic mechanism is ultrasound. Basic mechanism is ultrasound. Okay, but it is customized to the different purposes, nothing else. Okay, so now when we talk about the echocardiogram, okay, when we talk about the echocardiogram, there are multiple types of echocardiogram you have heard of. Let's start from the fatal echocardiogram. What is fatal echocardiogram, guys? Yes, fatal echogram. Fatal echocardiogram. Fatapat, you guys tell me. We'll end the class in 15 minutes. Okay. For fetus, pregnancy, fetal echocardiogram is to check the fetus heart and the activities of the fetus heart inside the womb of the pregnant women. Okay. Pediatric echo is different. Fetal echo, I mean fetal echo is different. Fetal echo is to check the heart of the fetus inside the womb of the pregnant women. Okay, nothing else but the echo which is used there. So what is the difference between fetal echo and the normal echo? See, there is a difference of the frequencies, difference of the frequencies, which like in the fetal echo, frequencies are more sharpened, but not at the higher intensities. Understand why? Because it can cause harm to the, harm to the, it doesn't cause harm to the patient at all. It doesn't cause harm to the babies at all. But the difference here is the sharpness. Okay, sharpness of catching the echo sounds is more higher in the baby's echocardiogram, like fetal echocardiogram. So it can catch all the sounds of the baby's heart. Okay, and it is customized one just to check. And here the probe is also very here the probe is also very small. Not the bigger probes are used in fetal echocardiogram is a lot. What is applied during procedure? What that gel is applied? Okay, what the gel, Ankit Sharma? Please tell what is the gel. People are asking what is the gel. Yes, that is conductive gel. Conductive gel is what, guys? It helps getting the sounds better. Okay, this is not the lubricant there. We don't use the lubricant there to so the probe can easily you can scale the probe easily on the chest. No, that is to make it easy, the process easy, and capture the sounds more efficiently. That is called as conductive gel. So you can easily capture the sounds of the heart and blood. Okay, it makes the uniform surface also over that. Okay, yes, right. So fetal echocardiography is one. Then the second thing is stress cardiography. Stress echocardiography is the similar echo but done when the person is given dobutamine. Okay, person is given dobutamine, so we check the heart functions in stress or during the exercise. Okay, during the exercise, understand, during the exercise. Why transthoracic echocardiogram is using? Wait, I'll come to that. Don't. Okay, so these are the normal echo or the transthoracic echoes. Okay, these are the transthoracic echoes. What is transthoracic echoes? The person is doing transthoracic echo. Transthoracic means the probe is on the skin outside the heart and taking the pictures based on the sound. It is taking the pictures or depicting the pictures on the screen and showing the functionality of the heart, right? Showing the functionality of the heart on the echo screen. But probe isn't put or outside the skin, I mean outside the body, I mean on the body at the chest. Okay, now this is the normal function, like where we capture the sound. And now the fourth thing you can see here, the three-dimensional echo. This is the very basic I'm telling. I'll tell you a little more about the echo, don't worry. So three-dimensional echocardiogram. Three-dimensional echocardiogram, usually we do the 2D echo, but 3D echo is nothing but when the echo is more efficient with the help of artificial intelligence, with the help of more technology, we create the images in 3D. Okay, when we are able to create the images of the heart in 3D, that is called as 3D echocardiogram, three-dimensional echocardiogram. Okay, and now I'll come to the transesophageal echocardiogram. What is transesophageal echocardiogram? And this I'm telling in the last only. That's I'm telling in the last only. Transesophageal echocardiogram. Tell me what is transesophageal cardiogram. Yes, guys. Transesophageal cardiogram, echocardiogram. Do you think, do you have any specific different mechanism of transesophageal? Do you think so? See, transesophageal is nothing but when we put the probe through our mouth. Okay, when we put the probe through our mouth to the GI tract near to the heart, and then we get the more precise sound from inside. Okay, we get more precise sound from inside. This is just nothing but like what the GI people do, what the GEC people, gastroenterologists do, what it is called as, what it is called as endoscopy. Okay, this is just like endoscopy. We put the echo probe inside the mouth to the GI tract. I mean, first, definitely, if we look at how it is being done, then first we, give some anesthesia, which, make our throat numb. So our, the probe is not, hurting us, or we cannot sense the probe. It goes inside, it checks the sounds, and it gives us the picture, the more precise and clear picture on the screen. And why we do the transesophageal cardiogram, echocardiogram, guys? Tell me why we need the transesophageal echocardiogram? Anyone? When we have the when we have the transthoracic, why we need the transesophageal? Yes, everyone, please tell me. It is simple. See, it has the very specific work. Okay, when the patient has the valvular heart disease, okay, valvular heart disease or the septal defects, septal defects. So to understand the size, to understand the size or to understand the mechanism, how they are working, or to understand the proper disease, or in case of cardiac infections. Remember guys, in case of cardiac infections, when we need to see the vegetation in pericarditis, myocarditis or endocarditis, like in pericarditis, pericarditis, endocarditis or myocarditis, when we want to see the vegetation, we need transesophageal echocardiogram because it shows us the proper image of vegetation. Okay, in case of valvular heart disease, when we have to check the proper heart function, heart valve functions, or when we had to check the size of septal defects like VSD, ASD, okay, or PDA, we have to check the size of the septal defects. We need transesophageal echocardiography. Okay, to check the normal heart functions like MI and other things, the mobility, motions, and everything, or ejection fraction, we can go for transthoracic echocardiography also only, right? And when unstable angina, stable angina, stress echocardiography for the kids, fetal echocardiography, and when we need the three-dimension images of the heart, we go for, yeah, we go for what? We go for the three-dimensional echocardiography. This is the basics. Now let me tell you guys, what can we, what can be checked in echocardiography? Tell me, what we can check, why we do echocardiography? Yes, I'll tell you. I'll not waste time here. I'll tell you. First of all, ejection fraction. What is ejection fraction? Ejection fraction is the function of heart. Function of heart, like the pumping capacity of the heart, right? Pumping capacity of the heart can be checked by ejection fraction by the echo. First thing is echo, and then wall motions. Wall motions, like in case of myocardial infarction, when oxygen supply is not proper, when oxygen supply is not proper to the different areas of the heart, it is like compromised wall motion. So wall motion abnormalities, we call that wall motion abnormalities, right? We only the contraction and relaxation is not happening properly, that is called as wall motion abnormalities, and it happens in case of myocardial infarction, so that can be checked in echocardiogram. Then the septal defects. Septal defects means ASD, VSD, or the size of these, PDA. Then the cardiac infections. Cardiac infections can be checked. The endocarditis, myocarditis, pericarditis. Then the valvular heart disease. Valvular heart disease means any valve of the heart or the pulmonary valve or anything can be done by can be done by echo. Okay. Other than that, like we check pulmonary arterial hypertension, pulmonary pressure we check by the help of echocardiogram, and rheumatoid heart disease can be checked by the help of echocardiogram. Fetal problems can be checked by the echocardiogram, and many other things we use echocardiogram to check all the heart functionalities, structural or non-structural. Okay, structural or non-structural, everything can be checked. Yes, vegetation, thrombosis, like when I'm talking about valvular heart disease, that comes the thrombosis, regurgitation, everything comes in this. Tricuspid valve, bicuspid valve. Okay, so all valves, all valve related problems come in the valvular heart disease when I'm talking valvular heart disease, right? So that comes in the, one sec guys, that comes in the valvular that comes in the valvular heart disease. Okay, so the echo is a very useful test, very useful test. It tells us more and almost complete about the heart, right? But we are talking, what we are talking. So now let me tell you some more, let me show you some more things. Okay, so this image, the first image showing ASD. What is ASD? Atrium, right? Atrial septal defects. Atrial septal defects, we call it a hole in the heart, right? Have you heard of hole in the heart, guys? How many of you have heard of hole in the heart?
hole in the heart, right? These are the holes in the heart. Okay, holes means there is no hole in the wall or hole somewhere. There are the septal defects, like there are the four chambers. There are the four chambers in the heart, and all four chambers are divided by the septums in between, right? Like right atrium, right ventricle, left atrium, left ventricle. These four chambers are divided by the septums. So if there are the defects in the septum, that is called septal defects. Okay, and that is called hole. Like when there is a connection between two chambers, usual connection, the not natural connection is through the valves, right? Natural connection is there through the valves, but valves are like one-sided thing. Like the blood is going from the atrium to ventricle, ventricle to the body or the lungs, and then it comes like there is the proper channel, right? Valves are the channels. But when other than valve, there is any mistake or fault or any connection between the between the chambers, that is called septal defect. So here, if you see in this picture, guys, focus the first picture. Okay, first picture, if you focus, this is right atrium, this is left atrium, this is right ventricle, this is left ventricle. Right atrium, left atrium, right ventricle, left ventricle. Now if you look at this, there is a hole between, there is a septal defect between right atrium and left atrium, like blood flow. It is just because of the sound. I mean, the sound is captured and it's showing that there is a blood flow between right atrium and left atrium at this site. So this is nothing but atrial septal defect between atrium, between RA and LA. There is a septal defect. This is ventricular septal defect, means this is again RA, LA intact. Nothing is there, no septal defects. This is RV, this is LV. And you can see here, this is the hole between RV and LV. I mean, this is the septal defect between RV and LV. I mean, there is a blood which is flowing directly between two chambers. That is VST. Okay, then AVST. AVST is nothing but atrial ventricular septal defect. So here is nothing but the entire atrium and ventricles are two chambers only. Okay, two chambers only, right? And so this is the normal heart, like where atrium, this is the like right atrium, left atrium. Here left atrium is this. Okay, left atrium is this. Then right ventricle, left ventricle. Okay, right ventricle, left ventricle, all are intact. These are the openings, but through the valve. These are the openings through the valve. Okay, and here if you look at, like again defect between LV. See, this is again RA and RV sorry, RA, LA, and then this is LV, this is RV. So there's a defect between RV and LV, ventricular defect. Here again it is showing the defect between upper chambers. Here showing the defect between upper chambers and lower chambers. This is like atrioventricular septal defect. Okay, this is the normal heart. So you can easily detect these things by the help of echo. By the help of echo, please differentiate thrombosis or embolism. Okay, so thrombosis is nothing but which is I mean definitely which is not floating. Okay, which is not floating. And embolism is also the, I mean, yeah, absolutely, that is the moving clot which is moving in the circulation. Okay, moving in the circulation, that can travel. Yes. Okay, patent ductus arteriosus is the PDA. Okay, yeah, can you explain ductus arteriosus? Definitely, I can discuss. Okay, so patent ductus arteriosus is nothing but there the two chamber septum is completely either like there is no proper separation in the chambers. Okay, there is no proper separation in the chamber. I mean, there are multiple congenital heart diseases. I have covered the entire congenital heart disease, pediatric cardiology. Last time we took the course on pediatric cardiology, I completed there. Okay, so let's not waste right now. I mean, we'll complete in the echo. Okay, so here this is the Simpson method. I'll just not tell you. I'll just tell you the name. This will increase your curiosity. This is the Simpson method of checking the ejection fraction based on the volume in the ventricle, based on the volume in left ventricle, volume of the heart and the pressure of the heart, which is needed to check this, the EF, ejection fraction, by Simpson method. That will be covered in the class definitely. So with the help of Simpson method, we check the LVEF, left ventricular ejection fraction, we call it EF, ejection fraction. So based on the Simpson method, we check the volume in the left ventricle and the pressure, filling pressure, like the output. Okay, and based on that we go for the Simpson method and we calculate the EF, ejection fraction. What is the main principle of detecting different heart abnormalities during echo? Main principle, echo, the principle is sound. Okay, principle is just sound of the blood flow. Okay, so these are the, and this is to check the heart failure, right? And this is to check the myocardial infarction based on the thickness, based on the motion of the wall. Motion of the wall is like there are scoring system. There is the scoring system. We call it wall motion score indexed, and based on that, like where is the wall motion low or higher? It is in the 0 to 6. I mean, it is 1 to 16. I'll not tell you everything here, but the increasing curiosity 1 to 16 here, and you can easily make out in the ECG, I mean the echo, like where is the wall motion. There are four types of thing. One is normal hyperkinesia, like when the wall motion is perfectly normal. Hypokinesia, where the wall motion is little decreased, so it shows that stable angina or unstable angina. When there is akinesia, akinesia is completely there is no wall motion, means oxygen supply is not reaching here and there is no relaxation or contraction. Okay, so the heart is like not functioning at all there. Okay, that leads to the ACS sometimes, or acute heart failure, or multiple thing decompensated heart failure. So I'll tell that later. Okay, usually in myocardial work. And dyskinesia is when the heart wall motion is completely abnormal. Okay, not slower, not higher, but is completely abnormal, sometimes higher, sometimes slower. So there are multiple diseases which shows dyskinesia also. Okay, so wall motion is either normal, little less, or completely gone, or dyskinesia. Okay, feedback link will be shared, guys. Wait, control. Okay, now it comes to the angiogram. I may not be able to describe completely, but I'll tell you in these two pictures from that patient we took, right? So this is the right side of the inside the heart from the angiogram. So let me tell you a little bit about the angiogram. Angiogram is the process where we put the catheter inside the heart. Catheter is nothing but a wire, the very small capillary, very small capillary. We put that either through. Look at this. This is the radial arm. Like this is the radial. Okay, radial vessel in the arms, like right or left, anything. So usually we take the left radial. From the left radial we put, or usually sometimes, I mean, it is 50-50, anything, but right radial or left radial, we take the radial capillary, and from here we puncture the radial. We put the entire wire, which is called as the, what we just called that, what the wire is called as. Yes, guys. Catheter catheter. Okay, the wire is called as catheter. Okay, so Eisenmenger syndrome also I'll tell. Yeah. So when the catheter is passed from here, it goes to the aorta, okay, or sometimes, and then it goes to the heart atrium. I mean, the not atrium, the arteries, coronary arteries, and we put the dye there. We put the dye, and based on the dye, we look at the screen. Where is the exact problem? Where is the little flow, or where is the partial flow, or where is the complete flow, or complete blocking of the flow. Okay, where is the complete blockage of the flow? Where is complete blockage of the flow? So here in this CAG at the screen, we can show like right side and left side. Okay, this is left. Okay, this is left side. So right side is like, see, from here we put the dye, and based on the dye we see. So look at this. This is the right coronary artery. This is RCA. Guys, this is RCA, right coronary artery. So right coronary artery, you can see there is 100% flow. There is 100% flow. There is 100% flow. There is 100% flow. But at the anterior part of LA, I mean anterior part of RCA, right coronary artery, if you see here, sorry, yeah, here the flow is just 10 to 20%, just 10 to 20%. This is 100% flow, right? Perimeter, why it is 10 to 20% is shown like this is the perimeter. It is not like See, it is going like this, and then it goes like this, and then it goes like this, and then again it goes like this. So this shows that here is the block. Okay, means from here to here, from here to here, entire thing is black. Entire thing is black. Entire thing is black. Blood flow is just this much, either 20%, 10 to 20% in this. Okay, so this is the blockage of the heart, guys. This is the blockage of the heart. Here is the blockage in the capillary. Okay, here is the coronary artery. You know, catheter size are different. Okay, there are the catheter sizes different based on the different patients. Okay, that will talk in the next class, definitely in the CAG class, but not today. Okay, so I was telling, this is like radial artery. Okay, from here we can put, or we can put the same, I mean we can put the wire from where, from femoral artery. Where is the femoral artery? Femoral artery is from the groin side. Groin, right, near to your thighs, like from where your thighs start, there is the femoral artery. Okay, so either here or there we puncture, and from there we pass the catheter, and then it goes through the aorta, it goes to the heart. We put the, you know, dye, and we check where exactly the mistake is. Okay, so this is the right side, this is the left side. Okay, left side is like the main artery. The starting first point of the left artery is called as LMCA, left main coronary artery. LMCA full form is left main coronary artery. Coronary artery. And then it divides into branches, like two major branches. First major branch which goes is LAD. Then the first branch, I mean this is the continuation of the LMCA, but the first branch is called as LCX. Okay, this is the LCX, and then OM, then D, and then, I mean, these are the multiple branches on the left side. Left side is more prominent because we have, this is the more prominent because left side has what? Left side has what, guys? Left side of the heart has what? Why left side of the heart is important? Are because we have the left ventricle, right? So left ventricle wall is more strong, and it needs more nutrition, it needs more impulses, and it needs more oxygen to relax and contract. So we have multiple, differentiation and multiple parts of left side, right? Multiple parts of left side. So there we need more access to the oxygen, so we have more part or partitions of the arteries. So the first part is called as left main coronary artery, then continuation of this is called as LAD. Who will tell me the full form of LAD? Who will tell me the full form of LAD? Who will tell me the full form of LCX, OM, and D? After this we'll finish the class, guys. Just 5 more minutes, don't worry. Left anterior descending artery. Left anterior descending artery is LAD, definitely. And then we have LCX. LCX is nothing but left circumference artery, and then OM, and then diagonal arteries. These are the diagonal arteries, right? So similarly, as we have seen in the right side, we can see in the left side that there is no flow in the LMCA, there is no flow in the LAD, there is no flow. So I'll take these all tests completely comprehensively in the classes, guys. Okay, I'll take in the classes. Okay, so I think we have discussed all, guys. Final diagnosis for the patient we're not going to discuss. So with that, thank you very much. If you have the questions, you can ask me. And now I will share the feedback link with you, guys. Let me see where is the feedback link. Okay. Okay, guys, so please ask me the questions. Thank you is fine. Okay, thank you is fine. So let me share. This is the feedback form, guys. I hope you got it. This is the feedback form. And if you guys want to register for the course, complete course, here is the link. This is the link for complete course. Please register now. Okay, please register now for this course. I'm expecting a lot of participation from your side, because this course is going to be a wonderful course for, like, this is not for the MBBS or MD people. I prepared it for the other healthcares, the basics. Okay, I prepared this course
completely for you people, so you can understand the radiology. Like the first module we covered all the biomarkers, second module we are covering the radiology, microbiology and all. So I am looking for a lot of participation from your side. Okay, so yeah, if you want to register, please register. Okay, let me see the questions now. I'm sharing the link again. This is the registration link, and this is the feedback link, guys. Okay, so let me see the questions now. After catheter. Okay, difference between angiography and angioplasty. Angiography is the diagnosis test, diagnostic test. Angioplasty is the solution where we put the stents inside the capillary, inside the coronary artery. So angiography is the test and angioplasty is the solution. Understand? Angioplasty is the solution. Angiography is the test. I'll take more comprehensive things on that. Can septal defects be able to cause hematoma? No, usually not. Sometimes, but not. Can we still join the class? Yes, I'm sharing the course. This is the feedback link. This is the link for the course, guys. Please join the course. Okay, if you want to, definitely. Okay, other questions? It was a nice presentation. I have gained information about cardiology. Thank you. So please differentiate thrombolism. Okay, this I've described before. I think you people are very intelligent. Difference between CT angiogram and CAG. Okay, so CT angiogram is something different. CT angiogram is like, again, they put the dye only, but it is CT guided. Okay, that is CT guided. CT is what? CT is computed tomography. Okay, CT is computed tomography. That is the another process. Okay, that is imaging. That is imaging. I mean, here also we are getting imaging only, but like with the help of catheter and dye, we are using the X-rays, the high intensity X-rays, and we are getting the imaging. There we are getting the computed tomography imaging. That is the difference between CAG. CAG is the normal thing, and CT angiography, but the precise results what we get is with the CAG. Okay, which lead is more accurate, 3, 5 or 12 lead ECG? 12 lead ECG. 12 lead ECG is the standard ECG. What about Eisenmenger syndrome echo findings? See, echo finding for Alzheimer's syndrome. First, there are two major criterias for the Eisenmenger syndrome. Is one is septal defect that you can easily detect in the echo. Second is pulmonary hypertension, pulmonary pressure, that also you can easily detect in the echocardiogram, right? And cardiac functionalities, like it leads to heart failure usually sometimes, so you can easily detect that. So two things are major in Eisenmenger syndrome: high pulmonary arterial, hypertension. I mean the pulmonary arterial pressure high, and then second is septal defect. Okay, along with that, sometimes there is polycythemia, high hemoglobin also. Okay, I'll tell it later. I mean, I'll teach us Eisenmenger when we are talking about the echocardiogram. Okay, when the classes will start? Classes will start, I think, soon, day after tomorrow, or yeah, maybe Sunday or something. Even a short intro on ECG has helped a lot. Okay, thank you. After this course, will we get any master's course certificate? Master's course certificate if you are covering both volume 1 and volume 2. Okay, volume 1 and volume 2. I mean the module 1 and module 2. So if you have covered the module 1, then you will definitely get the master's course. Otherwise, you will get the separate certificates for separate things. How to identify any abnormalities by seeing an ECG chart? I told you the everything is between P to T. Like, so there are abnormalities. Like if there is no P wave, it goes to arrhythmias. Okay, if there are frequent waves, or high intensity waves, high impulses waves, different things can be easily detected in ECG. All the arrhythmias, heart attacks, myocardial infarctions, different types of myocardial infarctions. As I showed you with the examples, like what is ST elevation, what is T depression, what is ST depression. So these things easily can be detected. Okay, Sanjay? Yes, in ECG, different problems, yes, different abnormalities generate the different sounds. Yes, true. Yes, one ECG class will be there. Complete ECG class I'll take. If you want comprehensive knowledge, guys, join the course. Literally 299 is nothing, literally. Yes. Hello, sir. Completely out of context, but have seen waiting for medical coding course. Medical coding course. Okay. Medical coding course we are coming up very soon. I mean, we'll be launching in June, first week or second week. Certificate for the demo you will be getting. Okay. Okay. Are these are the images not taken by me. Mohit, I'm not sure which particular position the patient was lying on, but usually we get the side or the dorsal view. Dorsal view, okay. Torsionary points also we will cover in ECG pattern. Yes. Credit score. We don't give the credit score, but we give the credit points. Yes, credit points we give. Vigilance course also we are launching. We have launched very wonderful course, guys. If you want to join, we have one more course like cardiology. I mean oncology. We are showing you tomorrow. But if you, I have one more course for you. If you are really interested, guys. If you're really interested. Oh, okay. Let me share the links in YouTube also. YouTube people are waiting for that. Yes, 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 guys. I'm sharing. This is the registration link, YouTube guys. Okay, this is the registration link. Okay, this is the registration link, people here, and this is the feedback link. YouTube people also please fill the feedback. You are also participating in that. You are also taking care. I mean, giving your time and working. So YouTube also there are some more queries. I'm not getting any queries. Just regurgitation, stenosis. I mean, you guys are answering well. So fantastic, guys. Okay, so here are the links. First link is for registration. Second link is for your feedback. Okay. Yeah, I'm sharing the link again. 1 second, I'm sharing the link again. Current affiliation means where you are studying right now or where you are working right now. Current affiliation means the institution where you are working right now. So I shared the registration link again. I shared the feedback link again. Feedback link will be finished in 2 minutes, guys. We'll close the feedback links in next 2 minutes. Please fill it now. Okay, please fill it now. Feedback link we will close. So why not 2D echo for stable angina? Because it will be normal. There will be no abnormalities. Vaishnavi, there will be no abnormalities in 2D echo when the patient is in stable angina and on the rest. It's fine. Venkata. Yes. No need. It depends on the first we do ECG, then we do echo usually. Okay. Guys, so again, last time I'm sharing the link. This is for registration and this is for feedback. Please fill it right away. And then we'll be closing the links in 2 minutes. Okay. I mean the feedback link. Okay, guys. Okay, guys. So take care. Good night. It's 9:10 already. So take care, guys. Yes, yes. You will get the certificates definitely. Thank you. Thank you, guys. Yes, Mohit. There are the difference between the mother's heartbeat and fetal heartbeat. Yes, definitely. That's why we need the sharpened one, which can catch and which can differentiate the frequencies easily. I want to enroll for module 1. You can enroll later. First, you enroll for the module 2. Enrollment for the module 1 will be opened soon again. Okay. Thank you, guys. Chalo, we'll see you guys later then. Take care. Good night. Yes, tomorrow's class will inform, but it is 7 o'clock. Yeah.